Welcome back everyone. In this lesson I will discuss about stridor in the newborn part 1, about approach to a neonate with stridor. In the part 2 of this section I will discuss about common cause of stridor in the newborn. To start from the anatomy of the airway that gives stridor, the airway can be broadly divided into clinically relevant segments. Obstruction of the nasal passage, nasopharynx, oral cavity, and oropharynx can produce obstructive breathing sounds that are usually stertorous in nature. Whereas the anatomic regions that produce classic stridors are the larynx and the trachea. The larynx is divided into the supraglottis, glottis, and subglottis. Supraglottic segment of the larynx includes the cartilages and the folds above the true vocal folds, whereas the glottis is a true vocal folds and the subglottis is 1 cm of airway below the vocal folds. The trachea begins below the subglottis at the inferior border of the cricoid cartilage and ends by branching into the right and the left main bronchus. On a clinical evaluation of such neonates, we should have to start with history as always. The history of a neonate stridor is critical in considering its likely causes, and the following are features of the stridor about which caregivers should be questioned. The first one is time of initial onset. In most cases, stridor in a newborn will be due to congenital anomaly and therefore present or it starts at birth. Even laryngomalacia, which can be reported as manifesting in the first week after birth, is usually present to some degree soon after delivery. But most of the time, the obvious symptoms of laryngomalacia starts after 2 weeks of life. In rare cases, masses or vascular compression of the airway, brainstem abnormalities, or perinatal iatrogenic injury to the recurrent laryngeal nerve might result in stridor in the newborn that presents postnatally. Examples include masses within the airway, mediastinal mass, vascular compression of the trachea, Kyrie malformation, and recurrent laryngeal nerve injury during congenital heart surgery or ligation of patent rectus arteriosus during newborn period. The second thing that we should have to ask is about the quality of the stridor. In general, extrathoracic pathologic condition presents with inspiratory stridor, whereas intrathoracic pathologic condition presents with expiratory stridor or wheezing. This rule holds up well in differentiating laryngeal abnormalities from those in the trachea. However, lesions of the glottis and the subglottis both may present with biphasic or inspiratory and expiratory stridor, making it difficult to distinguish lesions within the larynx based on the phase of breathing alone. The other thing that we should have to ask is progression of the stridor. Stridor that increases in severity or frequency over time implies an evolving pathologic condition such as compression from growing mass, such as infantile hemangioma, progressive stenosis following endolaryngeal or endotracheal injury, or increasing vascular compression of the airway. Stridor that is improving is more likely due to inflammation or due to laryngomalacia that is spontaneously resolving. The other thing is changes with position, such as prone versus supine, or changes with state of sleep and awake cycle. Changes due to position and or state are usually associated with lesions in the dynamic as opposed to static. Static means portions of the airways that are static, namely the subglottis and the trachea. When changes occur with positioning, the stridor is usually worse supine. This occurs primarily with laryngomalacia and subglottic pathologic condition. So, if stridor is worse during positioning of infant on prone position, that might be due to laryngomalacia or supraglottic pathologic condition. In this case, the symptoms are exacerbated by retropositioning of the tongue due to gravity. Stridor that changes with state is usually worse awake than asleep, and due to dynamic disorders such as laryngomalacia and tracheomalacia. Obstruction at the tongue base is generally worse during sleep. The other is changes in voice. Dysphonia manifested as a hoarse cry is associated almost exclusively with glottic pathologic conditions such as vocal cord paralysis or laryngeal wave. So if there is a change in voice or dysphonia or hoarse cry, we should have to think of vocal fold paralysis or laryngeal wave in a newborn with stridor since birth. The other is associated symptoms. Cough may be present in a variety of pathologic conditions, but it is seen most commonly in lesions that narrow in subglottis or trachea. Cough with feeding is often suggestive of abnormalities of vocal fold mobility or discoordination between swallowing and breathing, as is seen in laryngomalacia, but may also suggest a cleft of larynx or tracheoesophageal fistula. In addition, gastroesophageal reflex presence has been implicated as both a cause and a sequel of airway pathologic condition, and it's commonly associated with laryngomalacia. The presence of sternal retractions, progression, feeding difficulty or failure to thrive, and or acute life-threatening episodes often suggest a need for further intervention. And also birth history, intubation history, medical and surgical history, and family history are also helpful in determining possible causes. When we came to physical examination, assessment should first rule out severe respiratory distress, focusing on vital signs, and non-invasive assessment of level of consciousness, skin color, and accessory muscle use. If the patient is unstable, further management will focus on assessing and supporting the patient's airway, breathing, and circulation. Examination of stable newborn with stridor should focus on nasal and oral patency, as well as many of the features previously discussed, such as the quality of breathing sounds on inspiration and expiration, the presence of retraction, change in the pattern of breathing with position, and assessment of voice. A complete neonatal examination, including recognition of syndromic features, overall neuromuscular tone, and auscultation of the heart and the lung, may provide important additional information regarding possible cause of stridor. Assessment of the child's growth will provide further information about the child's overall functioning and ability to balance feeding with respiratory effort and caloric consumption. There is an algorithm called SPECS for evaluation of stridor newborn. S stands for severity of retraction and respiratory effort. P stands for progression, change in quality and severity over time. E stands for eating difficulties, such as prolonged feeding time, aspiration, failure to thrive, or reflex. C stands for cyanosis or apneic events or acute life-threatening episodes. S stands for sleep, such as sleep disturbance, change in stridor during sleep, not positioning during sleep. So we should have to ask severity, progression, issues regarding to nutritional status or feeding events, cyanosis or any acute life-threatening episodes, and also sleep disturbance, and associate the change of the stridor regarding to sleep cycles. Regarding imaging is rarely necessary in the assessment of newborn stridor, with the exception of those cases in which intrathoracic pathologic condition is suspected. A chest radiograph will occasionally demonstrate vascular compression of the trachea or mediastinal mass. CT scan with contrast can be used in the assessment of suspected masses of the airway, neck, or mediastinum, and CT angiography is diagnostic in case of vascular compression of the airway. MRI is particularly helpful in the assessment of vascular abnormalities, or if there is concern for Kyrie malformation in the case of bilateral vocal cord paralysis, and also to image the course of recurrent laryngeal nerve in the case of unilateral vocal fold paralysis. The final one is about the endoscopic assessment. In most cases, initial endoscopic assessment of neonatal airway may be performed with a flexible endoscopy in the otolaryngology office or as a hospital bedside. Flexible fiber optic endoscopy allows the examiner to visualize the pharynx as well as the supraglottic and the glottic larynx. Examination of the subglottic larynx and the trachea is more safely and accurately performed as an operative endoscopic procedure under anesthesia in the operating room. This is all about part 1 of approach to a child with congenital stridor or stridor during the neonatal period. On the part 2 of this section, I will discuss about the most common cause of stridor during the neonatal period.